to Medical ABC. Today we'll be talking about the ectatic conditions of cornea. As we have discussed in the previous videos, that the classification of the pathology of cornea includes many things like ulcer, dystrophies, and even ectatic conditions. So in this video we'll be talking about the main ectatic conditions of cornea, which is keratoconus. Then we'll be talking about the keratoglobus and keratoconus posterior as well. Keratoconus, from the term you can see, kerato is nothing but something related to the cornea. Conus, cone shaped. So cornea, if it is cone shaped, it's called as keratoconus. We know the normal shape of cornea, somewhat like a dome shaped. But in this condition of keratoconus, the cornea is cone shaped as seen in this figure. So normal cornea is actually a little dome shaped, while in this figure you can see it is cone shaped, just like a cone. So it's bulging outwards. So in keratoconus, conical cornea, it is a progressive, mostly bilateral, non-inflammatory condition. So it's a non-inflammatory condition, it's mostly bilateral, and it's a progressive condition. So it worsens with time. And there is ectasia of cornea in its axial part, not just the full cornea, the axial part, axial part of cornea, you can see ectasia. That is, there is a displacement, there is a distortion in the from the normal place, and usually seen in puberty. The theopathogenesis is still not clear, but the theories proposed by several scientists call it a developmental condition, or say it is a degenerative condition. Some say it is a hereditary dystrophy, and it could be even an endocrine anomaly. So these are the theories proposed by various people, but still the etiopathogenesis is not clear. The pathological changes you can see in keratoconus are the main two things. There is progressive thinning of central cornea. The central part of the cornea is very thin in this condition. Also, there is ectasia of cornea. There is distortion from its normal place. You know, when the shape itself of a particular structure is changed, there is a distortion from its normal position. So here the dome-shaped cornea is changed into cone shape. So there is distortion in its position. The clinical features include symptoms and signs. The symptoms the patient complains of include defective vision, which does not improve fully even with glasses. So even after the uses of glasses the doctor recommended, there is no improvement in the vision of the patient. Also there is glare, halos around lights, and light sensitivity and irritation. So the patient will also feel glare all over, and then they will see halos around the lights. Around the bright lights they can see halos. You know what are halos. Then there is light sensitivity, photophobia, and irritation in the eye. Often visual loss due to irregular astigmatism, myopia, and corneal scarring. So often, not always, but often you can also see irregular astigmatism leading to visual loss. So the myopia or irregular astigmatism or corneal scarring might even cause visual loss in this case. So we cannot say keratoconus will not cause visual loss. Often it also might cause visual loss due to these many reasons. Next are the signs. The main feature, the hallmark feature you should know about the keratoconus is that there is central or paracentral stromal thinning. Just in the previous slide I told you there is progressive thinning of central cornea. So this thinning is either central or paracentral. So the stroma, which is one of the layers of the cornea, the third layer of the cornea, is actually the thickest layer in the 6 layers of cornea. But in this case, in the keratoconus condition, the stromal thinning has caused the cornea itself to undergo thinning. So you can see the hallmark feature, you have to remember this in keratoconus, the hallmark feature of keratoconus is central or paracentral thinning of stroma. Then there is apical protrusion of anterior cornea and irregular astigmatism. So irregular astigmatism is, yes, it is there in keratoconus, and that is one of the main reasons there is visual defect. And the apical protrusion of anterior cornea, so there is also a protrusion of anterior cornea. So this is nothing but bulging out, this condition is nothing but a bulging out of cornea in cone shape. So there is a apical protrusion of anterior cornea and irregular astigmatism. In the bulging forward cornea, So you can see in this picture, this bulging forward cornea, the apex of cone is slightly below the center of the cornea. So this is a figurative representation of how the keratoconus cornea looks. I've taken this picture from Ectatic. You can see here, this is the apex. It is slightly below the center of the cornea. So normal cornea is actually, the center and the apex lies at the equal level. But in this case, you can see the apex or the bulging out portion is slightly below the center of the cornea. And on examination, a doctor can see these many things. First thing, on examination of a keratoconus patient, you can see the rings which are normally concentric in a normal person with normal eyes will be irregular in placido disc examination. So placido disc examination is done to see the topography or to see how the anterior surface of cornea is abnormal. That is, a placido disc is nothing but a keratoscope which is used to find out the abnormal curvature of the anterior surface of the eye, which is nothing but cornea. So this is used normally to see if there is any abnormality in the anterior surface of the eye. So in case of keratoconus, there is obviously an abnormality in the surface. The surface itself has become from dome shaped to cone shaped. So there will be irregularity which will be shown in the placido disc like this in keratoconus. So the normal eye, you can see this rings are concentric. The rings have equal spacing between them and they are all concentric. While in this figure you can see the space between the circles have lessened to the bottom part. Also, the rings are crowded inferiorly. The rings have crowded inferiorly on the placido examination. So this is a hallmark feature of keratoconus examination. So on examination, this is only the first mode to find keratoconus. There are many other methods. We'll see one by one. The first method is placido disc examination. The second one is slit lamp examination. In slit lamp examination, you can see many things. The first thing will be there is thinning and ectasia of central cornea. The main hallmark feature of keratoconus, which is thinning and ectasia. That is distortion and thinning of central cornea. You can see that in the slit lamp examination. Then there is opacity at the apex. Of course, you can see a perfect ophthalmologist can easily see the opacity at the apex of the cornea. Also, that you can see the folds in the Descemet's and Bowman's membrane. Often you can see the folds in the layers of the cornea, which are nothing but Descemet's and Bowman's membranes. Then there is Fleischer's ring, not Kaiser-Fleischer ring, not to be confused with Kaiser-Fleischer ring, which is seen in Wilson's disease. This is not that. This is just Fleischer's ring, which is entirely different from that. Fleischer's ring in keratoconus is actually due to iron deposition, and that is seen at the base of the cone. So Fleischer's ring should not be confused with Kaiser-Fleischer ring. Both are entirely different. And Fleischer's ring you can see in this figure actually. This figure you can see a circle which is marked by the yellow arrow. You can see if you can here. I'll zoom it. So yeah, this circle you can see here is nothing but the Fleischer's ring. Next is the next is that you have to know after Fleischer's ring, the main thing you have to remember here is the stromal striae, also known as Vogue lines. What are they? Stromal striae are they disappear on external pressure on the globe. So they are seen. Vogue lines you can see here in this blue thing. The lines have been not so visible, but after practice, after a lot of many patients coming to you, you can easily understand what Vogue lines really are. Stromal striae, otherwise known as, they are actually a very important feature seen in keratoconus, which actually disappear when the observer gives external pressure on the globe of the eye. So when you give external pressure, these lines which you actually see through the slit lamp will disappear. So this is a peculiar feature of keratoconus. Next is the third method for examination will be distant direct ophthalmoscopy. So distant direct ophthalmoscopy, you can see annular dark shadow due to total internal reflection of light, which is known as oil drop reflex. This is actually a PG point of question, but you can understand about this more as it is also included in your textbook. And the main feature that even the UGs have to know in keratoconus is Munson's sign. The fourth point in the examination is Munson's sign, where you know in keratoconus the cornea is cone shaped. Due to the cone shape, due to the over bulging of the cornea outside, what happens is that whenever the patient who's having this keratoconus looks down, when he gazes down, the eyelid, the lower eyelid also projects downwards. So the bulging of lower eyelid as the patient looks down is seen in this condition of keratoconus, which is known as Munson's sign. So Munson's sign is where the lower eyelid also bulges down along with the downward gaze of the patient. Munson's sign is a very important MCQ. And the final one is keratometry. You know what keratometry is done for. In keratometry, you can see the keratometric values. That is, they are increased in keratoconus. We know the normal keratometric value is 45 diopter. But in keratoconus, it will be either in these three ranges. If it is less than 48 diopter, it is mild. If it is like 46, 47 or less than 48, whatever it is mild keratoconus. If moderate keratoconus is 48 to 54 diopter and severe keratoconus is above 54 diopter. So the normal, you have to know, the normal keratometric value is 45 diopter. So above 45, that is below 48 and above 45 is mild. That comes moderate and severe keratoconus. Then there is corneal topography. So obviously the corneal surface itself has been changed here. The cornea has already distorted from its normal position. Also its shape has been changed. That is, it has changed from one to another shape. So obviously the topography will be different from that of the normal. So the earliest keratoconus is detected by corneal topography. So before all these signs have appeared, all these signs you have been discussing so far have appeared, you still can find if a patient has a keratoconus by just checking the corneal topography, because the main feature of this disease is nothing but the shape of the cornea is changed into cone shape. That's why the name itself says keratoconus. So the shape can be just checked by the doctor, and he can say from the first few days itself that the patient is having keratoconus. Even without waiting for these examinations, you can easily do a corneal topography and say the patient is having keratoconus by looking at the topography. And what is formae frustae? This is a very important MCQ. Formae frustae is the earliest subclinical form of keratoconus on topography. So the earliest form, even before the other symptoms or signs have arrived, this thing will be present if the patient has keratoconus, because the shape is changed. So on topography you can easily find. So formae frustae is the earliest subclinical form of keratoconus on topography. Next is a morphological classification. So keratoconus is classified on the basis of its shape and size. So if it is nipple, okay, so what are the classifications? We'll see one by one. The nipple cone is one type of keratoconus where it is where the keratoconus is very small, which is where the size is less than 5 millimeter, and this nipple cone is the smallest of all the three types. Then comes the oval cone. Oval cone is actually larger than nipple cone but smaller than globus cone. You can see the size is 5 to 6 millimeter, and it will be oval in shape. So why the name? Oval or ellipsoid in shape, so why it is known as oval cone. Next is the globus cone, which is more than 6 millimeter, being the largest of all the three types. And here what happens is it is globe in shape, globe-like in shape. So why it is known as globus cone. So just from the name itself, you can write 1 or 2 sentences about the type of keratoconus. Next is the treatment. Treatment of keratoconus includes spectacle correction for early stages of keratoconus, but you know it is not fully corrected if it has reached the middle or later stages. So for early to moderate cases, you can use designed scleral contact lenses, intracorneal ring segments. So how does intracorneal ring segments help? They actually help the flattening process to occur in the cornea. So the cornea is actually bulged in keratoconus, but the intracorneal ring segments will actually help to flatten out the bulged out cornea. And in very late stages, what you have to do? You have to do the surgery itself, which is keratoplasty. Keratoplasty is of two types. You can do either deep anterior lamellar keratoplasty or penetrating keratoplasty, PK. So it's either DALK or PK. So these are the two types of keratoplasty that you might want to do in the later stages of a keratoconus. So that is all about keratoconus on a whole. So it's a very important topic in UG point of view. Next, we'll go into keratoglobus. There is nothing much to discuss about it, so there is only one slide about keratoglobus. Keratoglobus is a condition where you can see the cornea is hemispherical in shape. It's actually not a full sphere, hemisphere. So it is actually bulging out just like our keratoconus, but just that the shape is different here. So it's known as keratoglobus. So it's like a globe, actually a hemispherical protrusion. And it's a familial, hereditary, bilateral, congenital disorder. So all these three terms you might have been always learning together: congenital, hereditary, familial. So just put all these three for keratoglobus and you get the definition. Then there is thinning and hemispherical. Yeah, thinning, of course, the main feature of all the ectatic conditions, just like our keratoconus. Here also there is thinning of the cornea, but here the shape is different. It is hemispherical protrusion, and this is a non-progressive, unlike our keratoconus, which is progressive. This is non-progressive, and this is an autosomal recessive trait. It is inherited autosomal recessive. Next is keratoconus posterior. So from the name itself you can understand, if the posterior part has bulging, it is keratoconus posterior. Same cone shaped, but bulging is in the posterior part. Just that difference alone, it is known as keratoconus posterior. It's very, very rare. So why? There is nothing much to talk about it. Thank you for watching Medical ABC. Do like, share and subscribe for more.